after brain. So for the causes, actually, we will talk about three common entities: the Cyada, cerebral salt wasting, and diabetes insipidus. All of them is mainly caused by uh, any CNS events like subarachnoid hemorrhage, traumatic brain injury, brain tumors, CNS infections, or it could be sometimes drug induced, as with some anti-epileptics like carbamazepine, for example. I like to classify them as a hyponatremic conditions and hypernatremic conditions. We will start with the conditions that result in hyponatremia. The first condition is Cyada syndrome of inappropriate antidiuretic hormone secretions. As we all know, that antidiuretic hormones is released according to the threshold of the thirst response. But patients with Cyada, their thirst threshold is lower than normal. The control of ADH secretion is impaired. There's also loss of control of antidiuretic hormone release, and plasma ADH concentration will not be affected by the continued fluid intake or even by the osmotic stimulus. The ADH concentration is therefore inappropriately high in the context of the production of a small volume of concentrated urine. So to diagnose Cyada, usually the patients will be hyponatremic. Their serum sodium will be less than 135 millimole per liter, and their serum osmolality will be low as well. Urine osmolality will be high. Actually, the hyponatremia is not as a result of sodium loss or sodium overexertion, but it's more of dilutional hyponatremia. The urine sodium concentration will be more than 80 millimole per liter, and these findings should be the diagnosis of Cyada should be made based on a normal thyroid, adrenal, and renal function. For the clinical assessment, it's always important to assess the hydration status of the patient. Patients with Cyada, usually they will have euvolemia or a slight hypervolemia, and there should be they're usually not dehydrated. The treatment of Cyada, the concept is to always treat the underlying condition if known, and to restrict the fluid, and to correct the sodium according to the sodium deficit with either 0.9 sodium chloride or 3%. In some patients, vasopressin receptor antagonist might be used, as they will promote the excretion of free water. The second entity is the cerebral salt wasting. Actually, this condition has a lot of debates and a lot of discussions whether it's really cerebral or renal. Some authors, they believe that it's a result of renal abnormality rather than cerebral injury. Anyways, it's defined as renal loss of sodium resulting in polyuria, natriuresis, hyponatremia, and hypovolemia, and it occurs as a result of centrally mediated causes. So to diagnose cerebral salt wasting, there's usually the serum sodium will be low. Sometimes it will be normal, and the serum osmolality will be low as well, and there will be high or normal urine osmolality. In those patients, their hematocrit, urea, bicarb, albumin, and also their creatinine might be increased as a consequence of volume depletion. As I mentioned before, this criteria is not really conclusive every time because you need to assess the situation of the patient and his clinical scenario. And again, we need to make sure about the volume status of the patient in order to be able to differentiate between Cyada and cerebral salt wasting. Usually patients with cerebral salt wasting, they will be dehydrated and they have significant volume depletion. The treatment is to replace the volume and to correct it with to correct the sodium level with 0.9 sodium chloride or 3%. Fluorocortisone might be used as it will limit the sodium loss by increasing the sodium reabsorption from the renal tubules. So to differentiate between Cyada and cerebral salt wasting, there is many elements in common between them. But to go over the clinical features, the patients with Cyada, they will have increased weight with a positive fluid balance. And patients with cerebral salt wasting, usually they will lose weight and their fluid balance will be toward the negative side. In the biochemical findings, both of them will have low serum concentration, low serum sodium concentration. The Cyada, as I mentioned, it might be as a result of dilution, and the cerebral salt wasting, no, they will lose sodium. The sodium balance is equal in Cyada, but in the cerebral salt wasting will be negative. And the renal function will be normal or decreased in Cyada as they have as their plasma volume is preserved, but in the cerebral salt wasting it will be increased. The hematocrit is the same as well. It will be decreased and decreased to normal and Cyada and increased in cerebral salt wasting. The other condition that cause hypernatremia is diabetes insipidus, and as we all know, it's either nephrogenic or central. Here we will discuss the central diabetes insipidus, or as some reference called cranial diabetes insipidus. Its incidence can go as high as 35% after traumatic brain injury, and it's associated with more severe injuries and increased mortality. If the patient developed DI in a non-pituitary surgery, it's usually associated with severe periterminal cerebral edema. So the presence of DI is therefore a common finding after brainstem death and has particularly relevance in the management of brain dead organ donors. So DI will result from a failure of antidiuretic hormone release from the hypothalamic pituitary axis, and the ability to concentrate urine is impaired, and this will result in the production of large volume of diluted urine. This is inappropriate loss of water that will lead to an increase in serum sodium and osmolality and a state of clinical dehydration. So if the patient is awake, the classic symptoms is polyuria, polydipsia, and thirst. But what we commonly encounter in critical area settings, mostly the patient will be either sedated or with low GCS intubated, so you cannot really observe these symptoms. But you will notice that there is increased urine volume. The serum sodium will be more than 145 millimole per liter, and also the serum osmolality will increase. Urine osmolality will be low, and urine specific gravity will be low, and although it's not really you cannot really depend on the serum and the urine specific gravity alone. There is another way to distinguish between nephrogenic and central DI, like the measurement of the level of antidiuretic hormone. But usually it's confirmed by the response to the synthetic antidiuretic hormones, like desmopressin. The treatment of DI is you need to target the restoration of plasma volume and a normal sodium level. So if the patient is awake with intact thirst mechanism, just drink to thirst only. If the patient knows, as I mentioned, like intubated, sedated, we need to replace the urine output 1-to-1 with either half normal saline, or sometimes we need to use different concentrations. and desmopressin supplementation. So in comparison, if we will compare the three entities, we need to keep in mind that patients does not present as a textbook like our patient Kayan. Uh, she has a picture of DI with hypervolemia, which oppose what I'm mentioning now. But patients will not be, as I mentioned, like a textbook. So in cerebral salt wasting, the volume status will be hypovolemic, as well as the diabetes insipidus, but we can differentiate between them by the serum sodium concentration. It will be increased in the DI and decreased in cerebral salt wasting. The urine sodium concentration, it's decreased in the diabetes insipidus patients, but it will be normal to increase in Cyada and cerebral salt wasting. Urine output is normal in Cyada patient, and sometimes it will be low, but it will be increased in diabetes insipidus and cerebral salt wasting. Actually, we usually get confused between these three topics, but you need to have a system in your mind to classify them. For me, I like to go with the hyponatremia, hypernatremia. At least it will keep one of them away of my differentials when it comes to hyponatremias. That's it. Any questions?